Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hanan, for this introduction. It is always difficult to talk after Prof. Suzanne with excitement, mashallah, wal hamas, وكذا. Inshallah, I'll try to keep you excited as I'll try my best, Prof. Suzanne. Now, practical issues with the use of tofacitinib. This talk is sponsored by Pfizer. I have a clear objective: safety issues related to use of tofacitinib. There are lots of talks and controversial points that I'd like to address with you today. And I'd like to review with you some of the latest evidence on the practical issues related to the use of tofacitinib, sorry. Yesterday was bari, today tofa. I'd like to present a new application for Pfizer, self-made, something I think will improve our practice. So I'll start with the practical questions, and I'd like to ask, because I'm not attached to my slides, I don't need to finish all the slides. My message here is to have more interaction. So this question: what is your first choice if your patient did not respond adequately to methotrexate, anti-TNF alpha therapy, or JAK inhibitor? So what do you think? So Dr. Sultana, what do you think? You are an expert rheumatologist. You'll go TNF despite guidelines still said TNF or JAK inhibitor, but you will go for TNF first? في mic يا جماعة, because my interaction is important for me. Yeah, mic. Khalid, Bayan, and mic. Yeah. Can you open it, please?
Well, the thing is, there are many factors in deciding which first biologic to use. First, the patient age, the comorbidities, and secondly, the risk factors are very important. Patient choice, if the patient is educated, they like to use subcutaneous injections, or some they refuse exactly. They don't like it. So in this case, then oral JAKs are a choice, that is. But usually, we have a large experience TNF, we have a large safety profile. We prefer to use the TNF. Before, we had some limitations at starting JAKs. Now it's readily available in the pharmacy. So there are administrative choices also.
Okay. Now, a question for the whole audience with the raise of hands. Following the oral surveillance study published recently by New England Journal of Medicine, the latest American FDA announcement about the limitation of the use of JAK, who is going to prescribe JAK inhibitors as a first choice, JAK inhibitor in general, not tofacitinib? Who's going to prescribe JAK inhibitor firstly after someone who failed or inadequate response to methotrexate? Hands up. So 2 only will prescribe. Wallah, Pfizer, wallah, you need to work hard on this issue. Okay, طيب. Who will prescribe, based on the oral surveillance study, your patient did not respond to methotrexate, who will start anti-TNF alpha first? Okay, majority. Okay, well, let's see. I'll ask you the same question at the end. I see if I'm succeeding or not. Anyway, I'm not trying to convince you to change your attitudes, but I'd like to discuss this matter with you. That's why we are having this talk. Are you willing to prescribe tofacitinib to RA patients above the age of 65 years of age? Hands up. Someone above the age of 65. Are you willing to prescribe JAK inhibitor to this patient? I'm talking about JAK inhibitors in general. Hands up. Depends. Prof. Suzanne, can the mic, please, Prof. Suzanne?
It depends on
the mic, please, Doctor.
As we said before, it's an individualized patient assessment and treatment. If the patient doesn't have any risk factors, if the patient is fit, because we know there are other comorbid illness that may influence our choice.
Okay, good. Type. Another question. Are you willing to prescribe tofacitinib to an RA patient with a history of solid malignancy? Difficult question. No, برضو, no. No one going to. لا جماعة انتوا سيئين مرة يا فايزر ايش هذا؟ حتى الليلي كل الجماعات الجاك inhibitors. Are you willing to prescribe tofacitinib to an RR patient with a history of DVT?
According to the recommendation, except if the patient is handicapped.
Okay, right. Well, let's see. We'll talk about it. What about tofacitinib and risk of malignancy? Do you think tofacitinib increase the risk of malignancy? Hands up. Does it increase the risk of malignancy? يعني في ناس بيقولوا 3. Okay, we'll see. طيب, are you willing to use tofacitinib in an RA patient as a monotherapy? Jack, as a monotherapy? Jack in general. طيب, كويس. هنا إن شاء الله ما حنضيع وقت كثير في هذه النقطة. From your perspective, what do you think your patients like the most, oral or subcutaneous or parenteral route? Oral. Okay, I'll not spend too much time here. Does tofacitinib work in seronegative as well as in seropositive RA? Yes. Sure? Yes, you're right. خلاص. Should you stop JAK inhibitors permanently if a patient develops herpes zoster infection? Permanently? طيب خلاص. Relax. Okay, so this is the outline of my talk. So after the questions, I will review the oral surveillance study. And I'll be repeating, in other words, the same words, the concept that I liked by Prof. Sultan and Prof. Suzanne. I will touch base on tofacitinib and malignancy. I won't spend too much time in monotherapy, mode of therapy, because mashallah, you know this already. Tofacitinib, just also touch quick bases on tofacitinib in seropositive and seronegative RA patients, and how to manage tofacitinib during herpes zoster infection. There's a good study that tells us something about how to deal with tofacitinib during herpes zoster infection. And Self-Made is an application designed by Dr. Bayan Darwish in Pfizer, and I had the pleasure to be part of this development just as a consultation phase. And right now it's used in application, and it's really, I think it's added more value to our patients' care. Okay, so this is oral surveillance study just published in January this year. As you know, this is a study that was done. Can you use the mic because I cannot see the slides here. So included patients above the age of 50 with more than one cardiovascular risk factor, and and RA duration was long, and they classified them. It's an open label design. 3 group of patients. They used tofacitinib 5 milligram, 10 milligram, and they used 2 doses, 2 regimens of anti-TNF alpha. And our primary outcome, or they set a goal for them to stop if they develop certain numbers of side effects. And the primary outcome of the study was to safety of tofacitinib 5 and 10 milligram versus TNF alpha. Co-primary to demonstrate if there is non-inferiority of tofacitinib in comparison to TNF alpha in terms of measured adverse cardiovascular events and malignancies. Okay, so this is from the study itself. Can I have the mic, the movable mic, if you don't mind? So the included patients, the mean age was more than 60, and 30% of the patients were more than 65. So they said more than 50, but actually the mean age was more than 60, and the mean age was the duration of disease was longer, and majority were white. So do we see more white patients in our practice? Do you think so? In our Saudi practice, less are black. Asian. The most common the most common cardiovascular events was hypertension. More than almost 60% of the patients were hypertensive, and they were smokers. And there were few patients who were having a prior history of malignancies or DVTs and PE. Okay, so this is again the same summary, but just to let you know, the mean age, keep this in your minds, was 60. Okay, now. Non-inferiority was not reached, so the risk factor for major adverse cardiovascular events was 47, 51, and 37. This is one of the primary endpoint, and they didn't show that the combination of both doses of tofacitinib was non-inferior to. So it seems that from what they want you to read is that TNF seems to be safer in comparison to tofacitinib. Okay, we'll talk about this in a minute. And this is the incidence of major adverse cardiovascular events. As you can see, it's lower with the TNF at the end. All tofacitinib doses are somewhat higher, but the 5 milligram, the one that is approved for rheumatoid arthritis prescription is not that much not great, no major differences between this and the TNF alpha. And the study itself, they did subgroup analysis for patients above the age of 65, and clearly the risk stands out for 10 milligram doses for those above the age of 65. How many of your patients are above the age of 65? And how many, are any one of us using 10 milligram BID? No. So this is subgroup analysis, clearly demonstrated that the risk is higher for those above the age of 65 and those with 10 milligram, which are not using in rheumatoid arthritis. Okay, subgroup analysis for malignancies. Same thing happened, less than 65, no major differences. Above 65 for 10 milligram dose and 5 milligram dose. And the two common malignancies that was raised, lung cancer and lymphoma. Okay, and we know rheumatoid arthritis is a risk factor for lymphoma. We know this age group is also a risk factor for lymphoma, for all malignancies. The critical things here, they don't have control group. Okay, and they did mention this in the limitation. And we all, as Dr. Suzanne was saying, we should read and interpret the evidence based on our knowledge. So this is a study that open label and has no control group. So what is the weight of that evidence? You need to think carefully. So this is the non-fatal serious infection. It was not from the primary outcomes of the study. They said it is somewhat higher with 5 and 10 milligram in comparison to biologics. I will mention in a minute the findings from real-world evidence, a true study that looked into many years and huge number of patients, and truly is the TNF alpha safer in terms of infection in comparison to TNF alpha to tofacitinib or not. So comments, as I said, open label trial design, no control group, and two types of anti-TNF. They compared not only to adalimumab, they put adalimumab in States and etanercept in Europe. What is the quality of this comparative data? So we have two drugs, and you label them as one category anti-TNF, and having one drug, tofacitinib, as the comparator. So, I mean, there is, lots of things that you need to look and see. Believe me, I'm just doing a full analysis here for all of us to make the right decision for the right patient. And I'll be repeating the words of wisdom that was mentioned earlier by Dr. Sultan and Dr. Suzanne. The other thing, is there a protective effect of anti-TNF alpha for the cardiovascular side effects or for the malignancy? We cannot say that. And again, but this is something that you may consider if you look at, especially if you know that anti-TNF alpha may be protecting from cardiovascular events, and some cardiologists are using anti-TNF alpha to prevent heart failure. These trials are ongoing. There is no proof yet. Is this population, I was claiming in the study, interestingly, it said that this population is truly representing RA population. I'm questioning you, I'm asking you, is this population in the study representing your patients in your clinic? Highly selective. Mean age is 60, and they do have cardiovascular risk factors, and mostly are hypertensive. So is this truly representing your patients in your day-to-day clinic? So you can answer this question yourself. This is the FDA. My problem with this, the FDA, two things. First, they extend the consent to other JAK inhibitors. You can think of, I will not comment on that, but I found it really surprising. They put recommendations for us how to use limiting approved uses of JAK inhibitors. الكاميرمان أصر إنه يوقف هناك على هذا الموضوع. تعالوا شوية. If they limiting all approved uses of JAK inhibitors to certain patients who have not responded or cannot tolerate one or more TNF blockers. So the study was on highly selected group of patients above the age of 60, and mean age of 60, and they are putting recommendations for all our patients. So I really found this really strange, and I don't see, honestly, the science behind it. This is overcautious, and it doesn't go with the findings of the study. Regardless if you believe or don't believe the study, but no, this was an overcautious one. Look at the comments from European Medicine Agency. It was more a wiser statement. They said tofacitinib not JAK inhibitors, all JAK inhibitors can only be used in patients above over the age of 65 if no suitable treatment alternative is available. I may not entirely agreeing with this, but again, it is a wiser statement compared to the FDA. And they are running safety reviews for all JAK kinase inhibitors for inflammatory disorders. The ACR had a statement as well, and they are updating it. This is the latest one. This is the updated version. And they said it's limiting, they described what was the finding of the statement of the FDA, and inadequate response or intolerance to more TNF. So this is the only indication. So they are changing the guidelines, not anti-TNF or JAK inhibitors. If you are inadequate responding to methotrexate, you have to use TNF alpha first and then JAK inhibitor. So what they like about comments from this, and this is the take-home message, is shared decision-making, and you need to select your patients highly, carefully for initiating JAK inhibitor, okay? So it's not something because I know some colleagues didn't prescribe JAK inhibitors as first choice for those who are intolerant to methotrexate. They were over-reading, over-interpreting the study. Honestly, that shouldn't be the case. I know this is a Pfizer session, but wallahi, I'm talking as a frank scientist looking at this study and reading for the entire thing. Did I change my practice? Like other colleagues from rheumatologists, I attended several sessions, several discussions. I didn't change 1% of my practice based on this oral servant study. Because the concerns that comes out of it, I'm already applying it. So we are concerned about DVT. We are concerned about the cardiovascular risk. But again, it's reassuring. I will show you that data, reassuring data about the major adverse cardiovascular events, and put a question mark on the things that was raised by the oral servant study. Okay, let's bring the real-world evidence. Two major landmark studies. One of them is the 9.5 years of long-term extension of all trials that address the use of tofacitinib in rheumatoid arthritis. And I know this is not real-world evidence. This is kind of prospective cohort of patients. So it's a big thing. All drug companies are talking loudly about it. It's good evidence, okay? But again, it is not real-world evidence. It's the cases that were, the RA cases who were treated in the trials, the long-term extension, and they looked into the safety issues in these patients. So it's not real-world data. Remember, it's prospective cohort of patients. But the announcement, the propaganda that comes around it, and there is evidence. It is evidence. It's reassuring. There is nothing that comes out as a huge safety signal from the use of tofacitinib in real practice. In all the extension trials, this is the published data. What I'm really liking is this one. It's the Corona registry from the United States. Huge number of patients, around 2,000 patients on tofacitinib compared to 8,000 patients on biologics. And this is truly real-world data. This is truly something respected. Jama'ah, 15% of all the information that we are gaining in to help us in our practice coming from randomized controlled trials. Only 15%. 85% of all the things that we are using in day-to-day practice is not coming from randomized controlled trials, coming from registries. And this, I'm not the one who's saying this. This is well-established evidence. And most of the information that we are, TB and anti-TNF alpha, does it come from randomized trials? No, from registries. Okay? So the conclusion is that in this registry analysis, both cohorts had similar major adverse cardiovascular events. This is the Corona registry. Major risk of infection, same risk of infection, same risk of MACE, serious infection, malignancy, death, VTE. The only thing that rose up with JAK inhibitors is Heber zoster. And this is I will show you all the details, but this is the conclusion. So how can you interpret then the oral surveillance study? You can, as my colleagues here said, in elderly patients, in those who are having already established cardiovascular diseases, but someone with 65 years of age, he has or she has no hypertension and no ischemic heart diseases and no diabetes, wouldn't you prescribe JAK inhibitor? I will prescribe it. And I have patients 80 and 95 and 70, ala tofacitinib and other JAK inhibitors. I'm monitoring them, I'm following them, and they are fine. Okay, so again, from these two studies, you can see you look at the major adverse cardiovascular events in the long-term extension trials for 9.5 years, symmetrical findings for all tofacitinib doses, and also in comparison to the corona registry between tofacitinib and all biologics, including anti-TNF alpha. And this is again for myocardial infarction. No signals, no safety signals are raised at all. This is again for malignancies. No safety signals again are, so tofacitinib does not increase the risk of malignancy in these registries and the long-term extension, okay? So in the elderly population, in that study, well, you need to, there is no control group, so you cannot per se, and based on one study, to conclude that tofacitinib increased the risk of malignancy. And I'll leave this with you. You think about it. Of VTE, if there is anything, if this tofacitinib was better than other biologics in terms of venous thromboembolism, okay? But no significant difference was observed. So this is, again, from the study itself. The only positive things was the herpes zoster. Infection was symmetrical. The herpes zoster was higher with tofacitinib in comparison to other biologics. And this is interesting findings. So if there is anything, as I said, tofacitinib was better for major adverse cardiovascular events in comparison to other biologics, and herpes zoster was worse with tofacitinib in comparison to the other biologics. Is this something new for you? Probably herpes zoster already established, and major adverse cardiovascular events as a protective in comparison to other biologics in the corona registry, around 10,000 patients. This kind of new for me, okay? But I'm not so much surprised about this finding. That's why what I'm trying to say here today, just be careful when you are reading studies, when you are interpreting them, and don't overreact. I hear some countries stop prescribing JAK inhibitors as a first choice in patients with rheumatoid arthritis based on oral surveillance study. I don't think this is fair, honestly, and I don't think some of us are fair if they are stop using JAK inhibitors to patients who are inadequate responders to methotrexate just because of oral surveillance study, over-interpreting or over-reading the study. So this is our patients who are from our rheumatoid arthritis Saudi database. I took permission of Prof. Suzanne, she's sharing with us, and Prof. Jamal Atiyah from Saudi German Hospital. We have 86 patients on tofacitinib since 2014, and we are doing great. So collectively, low disease activity and remission up to 60% are remission low disease activity. So still we have moderate disease activity, 35 patients. We have 3 switched to baricitinib, and 1 switched to Humira. And the full analysis, as I said yesterday, will be collecting data, and we are welcoming anyone who wants to join us. Right now we have 1,500 patients RA, and we're expanding to Medina, Dr. Badr, Mustashfa Irfan, and we're looking for more colleagues to join us. يا ريت المستشفى الحرس تخصصي أتمنى. So this is something sponsored by Pfizer, by Lilly. We're not hiding anything, any information. You can, we have 3 publications so far. Anyone wants to join us, he's or she is more than welcome. So tofacitinib has wide experience, lots of publications, 9.5 years, almost 8,000 patients, 24,000 patients years exposure. I mean, the data are there. I don't think oral surveillance study truly added some major kind of safety concerns for us. Honestly, for anything, it added some confusion and some disturbances for the practicing clinicians. Tofacitinib and malignancy, quickly 2 major data published in 2017 and 2014. One of them was in the annals. JAK inhibitors, or tofacitinib does not increase the risk of malignancy. This was systematic review, and this was from all the trials using tofacitinib. This was the trial that was published in Annals of Rheumatic Disease. So it is well known that tofacitinib does not increase the risk of malignancy. Another systematic review looking at combination of tofacitinib plus methotrexate in comparison to methotrexate alone. If this increases the risk of malignancy, the final conclusion, it does not increase the risk of malignancy. it's a reassuring thing for us with the tofacitinib in terms of risk of malignancy. I'm just mentioning this to you. And you can make your own judgment if you believe this or not. It's your call. Monotherapy, I won't spend too much time, but this is Australian study, addressed all the issue of monotherapy or combination therapy for their patients in the registry, including all biologics and non-biologics like targeted synthetic DMARDs, and they showed that monotherapy is really good, even for biologics. So patients tend to have really good response to therapy if they are on monotherapy, whether on TOFA or other JAK inhibitors or biologics, but they didn't address immunogenicity and the long-term survival for these patients. And this is another issue, but we should be thinking heavily about considering monotherapy, because I'll mention this later in a study where patients do not like, as Professor Suzanne was saying, do not like the combination of methotrexate and with other drugs. Okay. So this is the study that was oral shift study. You have heard about it, and if you have patients, if you have patients on methotrexate and tofacitinib who achieved low disease remission, they were randomized to two groups: monotherapy alone and tofacitinib alone and tofacitinib methotrexate, and there were no major differences between both of them. And this is a very reassuring study to use tofacitinib as a monotherapy. Mode of therapy, you know this, I will not spend too much time, but I will just, in different RA population, German, Australian, patients tend to prefer oral therapy. We have our own study, inshallah will be published soon. 80% of our Saudi patients like oral therapy, 80%. So I will just skip the slides because of time. And interestingly, patients do not like combination with methotrexate. So they like oral therapy and no combination with methotrexate. So this is a really preferred mode of therapy for our patients in that study and for our Saudi population as well. This is another study. Again, oral therapy is the most preferred therapy for patients. It works well in seropositive and seronegative. Just let's skip that. Managing tofacitinib in time of herpes zoster infection. Would you stop the drug if you have tofacitinib and patient developed herpes zoster? Would you stop tofacitinib? Would you continue tofacitinib? Okay. Would you maintain patient after treatment on tofacitinib? Yeah. Okay. So all the answers are correct. So this is interestingly. So most of all the trials, patients who developed herpes zoster. So most of patients maintain tofacitinib, and some of them, temporarily discontinued, and some of them maintain. So either one of both are, there is no right or wrong answer. Myself, I tend to stop, and if you maintain, it's fine. The evidence, the others have done the same. But most of patients did receive antiviral treatment. Okay, so most of them, and most of the cases, reassuringly, it's mild to moderate. There were no severe cases with herpes zoster infection in patients with JAK inhibitor. Okay, advances happen. We the early drug was tofacitinib, then followed by baricitinib, and now upadacitinib. So these are new classes of drugs that are really of great value, and we can use them safely. Self-made application. This is, you can have it well described in Pfizer booth. Okay, so something we are using right now is applied on patients. They collect information about disease activity, HAQ score, DAS score for different diseases, and the patient can fill the information and can submit these results to you directly. They collect workability, CDI, HAQ score, and I think it's added value to our patients' care, particularly with the era of social issues and applications. So summary, conclusion, tofacitinib is a safe drug with careful selection of your patient. So this is the message, ya Jama'ah. Careful selection of your patient for the TOFA. So again, ask you again, if your patient with inadequate response to methotrexate, who's going to start JAK first? برضو? Who's going to start anti-TNF alpha first? Okay, so I'm not, I just want to raise this issue for you. So think about it. Don't over-read the study of oral surveillance, and don't let it to affect your practice. Anyway, Tofacitinib is effective as monotherapy. One of the major advantages of all JAK inhibitors is the oral route. Tofacitinib can be used effective in all forms of RA, seropositive, seronegative. You can either help temporarily or continue the drug if the patient develops herpes zoster virus infection. Self-made is a promising tool. Thank you very much.